right, thank you so much. So as Teo mentioned, today I'm going to be presenting some work I've been doing on the CASAH project. I'm looking at trajectories of psychiatric disorder among adolescents and young adults affected by HIV. Sorry.
For those of you who haven't been here over the past couple of months, we have switched technologies, and so far we're
Okay.
like, 10% on having trouble.
Oh, okay, perfect. Okay. So as many of you know, there have been significant advancements in HIV prevention and treatment that have really dramatically transformed the perinatal HIV epidemic into one that's now of adolescents and young adults. So in the United States, there are approximately 11,000 adolescents and young adults with perinatal HIV infection, and a large proportion actually live in New York State. And as the first population to grow up with perinatal HIV infection, this group faces some really unique challenges that might increase their risk for psychiatric disorder and also poor HIV health outcomes. And just to give a little context, just 30 years ago, these now young adults, they weren't expected to live past age 5. And then with the introduction of treatments that could prevent mother-to-child transmission in 1994, and then also improvements in HIV treatment, so combination or highly active ART in 1996, that really transformed the epidemic and also dramatically increased their life expectancy. So, they were surviving into adolescence and then also into young adulthood. And, obviously with this comes a lot of joy, but also a lot of challenges in terms of growing up with HIV. And so that's what I want to talk to you about today. So what makes this group so vulnerable to poor HIV health outcomes and also psychiatric disorders? So as I mentioned earlier, they were born before the advent of combination ART. Many experience delays in treatment initiation, so it's not like today where you're diagnosed and you start treatment right away. They also were exposed to suboptimal treatment regimens early in their life. Many experience time outside of HIV care and also periods of poor ART adherence, and so that led to also periods of unsuppressed viremia. In terms of context, many of these young people also grew up in environments that were marked with extreme poverty and violence. Many experienced trauma, the death of a parent, stigma and discrimination. And I think it's important to remember at the time the epidemic was concentrated in some people who were struggling with substance use issues, or women who had substance use issues, or their partners. And so many of these young people were also growing up in households where there was drug and alcohol use. And so that's just kind of these chronic life adversities also increase their risk for psychiatric disorders and poor HIV health outcomes. And then there's the challenging transition from adolescence to young adulthood. And so I think a lot of us try to forget what middle school was like, but it is a really challenging time. So there's enormous emotional, behavioral, and physical changes that are happening across chronic conditions. This is known as a high-risk period for poor adherence in general. And then also for those who are at risk, this is also when psychiatric disorders start to emerge. And so while there's a great deal of literature about the relationship between psychiatric disorders, in particular depression and substance use, and its impact on HIV health outcomes among adults, we don't know as much among young people, and in particular perinatally infected young people, and there are very few studies that have examined this longitudinally. And so given these gaps, we are interested in asking these 3 questions. So first, what are the trajectories of psychiatric disorders spanning adolescence through young adulthood? Second, what are risk and protective factors that are associated with these different trajectories, and what role does perinatal HIV infection play, if any? And then finally, third, among those adolescents and young adults with perinatal HIV infection, what's the association between these psychiatric trajectories and then risk of viremia in young adulthood? And so to answer these questions, I used data from CASAH, and actually I forgot to put the grant number, but this is Claude Mellon's study. And it's a longitudinal behavioral cohort study of perinatally HIV infected and then perinatally HIV exposed but uninfected adolescents and young adults. And so they were recruited when they were 9 to 16 years old from 4 major medical centers in New York City. And adolescents and young adults and initially their caregivers were interviewed every 12 to 18 months or so. And so this analysis uses data from baseline when they were on average 13 years old, all the way up through follow-up 5 when they were on average 22 years old. And I used data from all the follow-ups in which there was a full psychiatric interview. And so I'm going to go through this kind of quickly. These are some of the measures that we looked at, but I'm also happy to answer questions about these specific measures. And so, as I said earlier, the adolescents or the youth and the young and the caregivers were interviewed every 12 to 18 months, and this consisted of a very extensive battery that covered a wide range of questions, including sociodemographics and contextual factors. We also measured psychiatric functioning using the DISC, which is a validated tool for screening for psychiatric disorders as defined by the DSM. And we grouped the disorders into four major categories. So we were interested in knowing at each follow-up period whether people screened positive for any mood disorder, any behavioral disorder, any anxiety disorder, and any substance use disorder. And then we also looked at viral loads among the perinatally infected, and we looked at viral loads that were available in the 12 months before follow-up 5, and these were abstracted from medical charts, but also we did a blood draw at follow-up 5, so we also had that data. And we defined viremia as having 2 or more viral loads that were greater than 200 copies. And so the reason we did 2 or more viral loads is that we were really interested in, identifying an actual problem with viremia as opposed to just, a small blip. So in terms of the statistics for AIM-1, here we were identifying trajectories of psychiatric disorder. And so we used something called multivariate longitudinal latent class analysis. And we used this to identify trajectories of disorder from baseline when youth were ages 9 to 16 up through follow-up 5 when they were 18 to 28. And we did this among all of the adolescents and young adults. Then in AIM-2, we were interested in identifying sociodemographic and psychosocial predictors of these trajectories. And so we used multinomial logistic regression to estimate odds ratios and 95% confidence intervals for the association between these predictors and belonging to the different trajectories. And we controlled for HIV status, age, and sex at enrollment. And then finally, for the third AIM, we were interested in examining the relationship between belonging to these trajectory groups and having viremia in young adulthood. And so this was only among the perinatally HIV infected who also had 2 viral load results. And here we used logistic regression. Okay, so AIM-1, what are the trajectories of psychiatric disorder? And so we identified 3 distinct trajectories, and these trajectories were based on the co-occurrence of the psychiatric disorders at a given follow-up period, but also how these trajectories changed over time. So that's the multivariate part. So the most common trajectory that we identified, we named consistent low-level psychiatric disorder. And this made up of 68% of adolescents and young adults. And what you can see on the right is that basically over time, there was generally a low prevalence of having psychiatric disorder. So in this graph here, this dark blue bar is the prevalence of having any disorder, and then this light blue bar is the prevalence of having 2 or more disorders. So in general, there was a low level of disorder or prevalence over time. And you can see on here, this is the psychiatric trajectory. So on the y-axis is the probability of having a psychiatric disorder at a given follow-up period, and then on the x-axis are the follow-up periods. And so this basically follows epidemiological trends, right? What you would expect. So you see a decrease in anxiety over time. You see an increase in substance use over time as people are getting older. And in general, mood and behavioral disorders, the risk or the probability of those disorders remained low over time. Okay. So then the second group we identified, we named persistent anxiety, and this made up 22% of adolescents and young adults. And the reason for that name is because over time they had a persistent high probability of having an anxiety disorder, but really not very many other disorders. And again, this is reflected when you look at the prevalences of disorder over time, right? So most of them experience or screen positive for only 1 disorder over time. Although starting at around follow-up 4, you do see a little bit more, comorbidity, so 2 or more disorders. And that's being driven by a slight increase in mood disorder and then also a slight increase in substance use disorder. Okay, and then this third group we named Escalating Psychiatric Co-Morbidity, and they made up 10% of adolescents and young adults. And so, here you can see that starting just at enrollment, when they were on average 12 years old, 68% screened positive for one disorder, 38% screened positive for two or more disorders. And this just escalated over time, right? Such that by the time they were at follow-up 4, 100% screened positive for one disorder, 64% screened positive for two or more. And so what are these disorders, right? So, the most predominant one is substance use disorder, right? So it starts high at a little over than 20% probability when they were, 12 years old, and it just escalates, right? So by the time they're at follow-up 5, they had an 83% probability of having a substance use disorder. In addition, they were also, dealing with anxiety disorder and an increase in mood disorder. The only trajectory that decreased is this light blue line here. This is behavioral disorder. But what's actually really striking here is that even at follow-up 5 at its lowest probability, this is still higher than any other time point for the other two trajectories. So this is just a really vulnerable group. Okay, so some key takeaways from these results are that the good news is that in general, most people are doing okay. About 2/3 of the participants fell into that low-level group. And then, in general, the trends in psychiatric disorder were comparable to what we're seeing in other non-HIV infected but vulnerable populations. So as youth age, you see a decrease in behavioral and anxiety disorders and a slight increase in mood and substance use disorders. But the not so great news is that actually 1/3 had persistent psychiatric disorder. And so, a little more than 20% had persistent anxiety, and then about 10% had this escalating psychiatric comorbidity trajectory. And in particular, this group is really marked by this really extreme, substance use burden. Okay, so moving on to AIM-2, here we are looking at the risk and protective factors associated with each trajectory, and then also examining the role of HIV infection. So here, these are all of the protective and risk factors that we examined. I'm not going to go through all of them in detail, but I did want to include this here. And I'll just say that, what was a little bit challenging about this analysis is that, given that only 1/3 of people, fell into these two groups and only 10% fell into the escalating psychiatric comorbidity group, we did have small samples, and so that's why you're seeing these kind of wide confidence intervals, and not a lot of these findings are statistically significant. But I'm going to walk you through some of the things that I think might be potentially important and that should be examined in larger studies. So in terms of risk factors, for persistent anxiety, the most salient factor was being female. So, women had about 2 times the odds of being in this group compared to being in the low disorder group. There were more risk factors for escalating psychiatric comorbidity, so people who were older at enrollment, people who reported neighborhood stress, this was a really important one, and then people who had a caregiver who screened positive for an alcohol abuse issue were more likely to fall into this trajectory compared to the low disorder group. I also want to point out that, so we cannot conclusively say that HIV did or did not play a role because these results were not significant. And again, we had this issue with the wide confidence intervals that also span the null. I might conjure that, it's unlikely that having perinatal HIV infection increased your risk of being in these riskier trajectories. And actually, it suggests that maybe it might even be protective. But again, I think we really can't say from these results because the confidence intervals, suggest that it could be protective, but it also could be risky. And so this should be examined in other studies. In terms of protective factors, none of the protective factors were statistically significant. But some things that might be important are, so among, the people who screened positive for persistent, or people who fell into the trajectory of persistent anxiety, having a caregiver who is a birth parent might be an important protective factor. In general, having good caregiver-child relationship appears to be protective, and in particular, saying that having a high child autonomy might be important for both trajectories. And then for the escalating psychiatric comorbidity group, receiving public assistance may also have a protective effect. So these are things that may be promising to look at in the future. So to summarize, neighborhood stress and caregiver alcohol abuse are 2 modifiable risk factors that increase the likelihood of being in the escalating psychiatric comorbidity group. And so, interventions that can target these contextual and environmental risk factors while also drawing on the strengths of families and caregivers, because we saw that child caregiver relationship was also really important as a protective factor. Those two things might be a promising strategy for preventing or minimizing the long-term consequences of substantial psychiatric disorder. And then again, the relationship between HIV status and psychiatric trajectories was unclear in this analysis. So we found no statistically significant difference. But there may have been a few factors in this study that may have helped obscure the difference between these two groups. And so again, like I mentioned, there was a small sample size, and so we could look at this maybe in a larger study. But it's also possible that adolescents and young adults with perinatal HIV infection, they had greater risks for psychiatric disorder, but they've grown up with a chronic, highly stigmatized disease or illness, and they've learned to navigate the healthcare system. They're also, it's possible that they've developed coping and resilience skills that have, had a protective effect on them. And then it's also, we know from previous analyses in CASAH that this group is also more likely or more engaged in healthcare in general. And if they screen positive for a psychiatric disorder, they're much more likely to be in mental health care. So that also may have, they might be at greater risk, but they're also receiving more treatment. And then there was this other issue that where over time there was a little bit of unequal patient or participant attrition in CASAH. So the quote-unquote healthy or the adolescents and young adults who were perinatally exposed but not infected, who did not have a psychiatric disorder, over time they were less likely to be retained in the study. And so that may have had an effect of making the groups look more alike. So again, just something that should be examined more in other studies. Okay, so finally, moving on to the third question. So here we are looking at the relationship between the different trajectories and viremia and young adulthood. And so we found that among adolescents and young adults with at least 2 viral load results, 48% had viremia in the year leading up to follow-up 5, which is pretty shocking, I think. And the risk of having viremia was even higher, if you had the persistent anxiety trajectory. So those adolescents and young adults had 2.55 times the odds of having viremia at follow-up 5. And then those in the escalating psychiatric comorbidity group had nearly 4 times the odds of having viremia. So, these are really important risk factors. So the key takeaways from this is that, there's a lot of literature focusing on depression and substance use and their relationship with poor HIV health outcomes. But actually, these findings suggest that anxiety may also be a really important risk factor, and it might be particularly salient to young people. And with more than 20% of adolescents and young adults screening positive for persistent anxiety, it's really something I think that should be examined further, and we really need to understand what's happening with this group. We also saw that adolescents and young adults with escalating comorbid psychiatric disorders are a very vulnerable group. The good news, I guess, is that they only made up 10% of the population, and so that means that we can devote more intensive resources to helping this group. So in conclusion, the transition from adolescence to young adulthood is a really challenging time when people are at high risk for psychiatric disorders, but there are many opportunities for prevention and treatment. So I think I've shown that the need for mental health screening and intervention is really urgent for perinatally infected adolescents and young adults. More than close to 50% had viremia in young adulthood, and the risk is even higher for those who had these persistent psychiatric trajectories. I would like to advocate for routine mental health screening. I think it should be a central part of their HIV care. Just like we would routinely monitor for viral load, mental health is a dynamic process. We need to constantly be evaluating this, and I think this will allow clinics to focus their limited resources on the people who are at greatest risk. And finally, I just want to end that by saying that adolescents who are perinatally exposed may be at equally high risk for psychiatric disorders. And so while the pediatric HIV epidemic is getting smaller and smaller in the US, this is not true globally. And also, we have not eradicated HIV in women. And so that means that there's going to be many young people who were born, perinatally exposed to HIV. And so I think it's really critical that we, address the substantial and evolving mental health care needs of this population. And I just want to say thank you to everyone, the CASAH team, in particular Claude. When I started this fellowship, I didn't really know anything about mental health, to be honest, and Bob and Claude have really schooled me in this area, and so I am really appreciative of that, and as well as the entire CASAH team. They have helped me a lot with this analysis, as well as our funders and the youth and their families, and also the fellows who've helped with an earlier version of this presentation. Thank you.
Very nice, concise overview. Thank you. And I assume that there are questions.
Besides being absolutely beautiful presentation and really tough things that have followed through, most of these young folks have been parenegally infected for 20 years. The behaviorally infected adults for 20 years, they have the same sort of presentation, except for the anxiety component that you have. Are you able to extract stuff and it gets confused all the time? Are you able to extract substance use, taking substance use away and focusing exclusively on the psychiatric component? Admittedly, substance use is a lot of self-medication for these, but removing because it mirrors the older adult population very much in terms of viral loads and so forth. And given that the saliency that you honed in on, the anxiety component,
Right.
I think that is, I try to make it as clean as possible.
Yeah, that's a great point. And I actually recently just submitted this as a paper, and like one of the feedbacks that I got, because I think the substance use in particular may also be driven by mostly like marijuana use. And so one of the questions is like, how much of it is just marijuana? Yeah. Right. Yeah, that's a great point, and that's something. Yeah. Thank you.
It's a great point. Kate did an analysis. I was going to say we found in this population that actually marijuana predicted anxiety.
Yeah, no, it's all.
Yeah.
But that's also true of the non-injury population.
Yes. They're not just self-medicating though. It's like the anxiety doesn't appear and then they start using marijuana. It's like it switches, so it's not a clear-cut thing. I don't know. I don't know that I would pull it out. I think that it's integrated in important ways. But I
would also remove, try to discuss marijuana separately from other.
Right. Yeah. And we're gonna explore exactly that.
It's very relatively little. Okay, I'm looking at my sheet because I'm not remembering always, but I think we have very little abuse of any other drug. Just alcohol and marijuana are the two drugs.
Yeah. Were you able to distinguish between like risky substance use and substance use disorders? Because it sort of looked like it was all substance use disorders. Did you have also, because I think that's also part of it, is that a lot of people may use alcohol or marijuana regularly or frequently without necessarily having a use disorder, and that might be very different.
Yeah, that's a
sort of lump it all together.
That's a great point, and I think one of the limitations, like this was kind of our first look at these trajectories, and we were trying to, and so there's a lot of collapsing that happened, right? So we grouped substance use disorder into one giant bucket, and the same thing is true for all the other psychiatric disorders, and so I think that's right, like absolutely right. One of the next steps may be to kind of start to tease out, when you have the psychiatric or the substance use trajectory, what is that made up of, and actually how is that changing over time, and exactly that, like how much, if you start to consider just risky use as opposed to disorder, what does that look like? So that's a great suggestion. Thank you.
And I just like to comment on that, I think from my understanding of what our participants are reporting anecdotally is that most of the time it is marijuana use as daily use that they don't see as a problem, but perhaps it is impacting their life. Perhaps they are self-medicating, but of course they don't see that to be the case. I think unlike the general population, most of our participants did not go to college. So what I think we found in CASAH 3, which is some of the follow-up, including follow-up 5 that Nadia is discussing, they weren't really using like harder drugs, cocaine and ecstasy and MDMA and things like that. But now, so they're kind of now in this new wave, CASAH 4, they're kind of playing catch up almost. So now they're experimenting with drugs that perhaps they're later in life, now they're in their late 20s, that perhaps the general population would have worked with in college, or that's what is expected. And I would say relatively low levels of alcohol use, actually. It's really marijuana use.
Any other questions? Just
Yeah, great presentation. Did you, I know HIV wasn't a predictor of the trajectories, but did you stratify by each of these guys? Was it different among?
Yeah, we thought about that. That was like a decision we had to make really early on, and we decided to put it together and instead look at it as a predictor. I am a little bit curious what it would look like if we stratified them, so that's something I think we could potentially explore and see if maybe that helps address some of the power issues that we experience. So at least you could qualitatively see if there are differences. So that's a great idea. Thank you. All right, thanks so much.
More work to be done, Nadia. Thank you so much.
Okay. All right, thank you, Teo, for that introduction, terrific introduction, and thank you everybody for being here. And it's actually great to be paired with Nadia's wonderful presentation, even though it's going to make me look a little bit amateurish. But I feel like what I'm about to present on is in a way sort of focusing in on the highest risk trajectory, that sort of increasing psychiatric comorbidity, and maybe sort of further down the line. Now a lot of this may be very familiar to people here in the HIV Center, but there may be a few twists that are going to be a little less familiar, so you may need to remind me to clarify things. But as we all know, and some of you probably did the pioneering work to demonstrate this, people who use substances are at increased risk for HIV and several other infections through multiple mechanisms, which include decreased inhibition during direct intoxication, which leads to riskier sexual activity and other activities. For people who have already developed an advanced substance use disorder, this sort of disinhibition may progress, and people may face survival challenges and resort to transactional sex, which can limit the ability to negotiate safety. There's been a description of substance use and violence and HIV as syndemic, and I think that Nadia's presentation spoke a little bit to this, about the way in which sort of community stress and community factors can concentrate infectious diseases and substance use within a vulnerable population. So some people may just grow up in a community that has more exposure to substance use and more exposure to HIV, or risk thereof. And then for people whose substance use progresses to the point of having a substance use disorder and injection, there is the added risk of direct transmission of bloodborne pathogens. HIV, but especially actually hepatitis C and hepatitis B, are more transmissible than HIV. And it's not just by sharing needles and syringes, but also other equipment used to prepare the drugs. Hep C can be transmitted through sharing of straws for snorting drugs or pipes for smoking drugs. So there is this added risk. And then finally, in addition to transmissible infections, there are also a number of infections that people develop, people who inject drugs that particularly develop by just directly inoculating the bacteria that live on our skin into the deeper tissues, the soft tissues, and particularly the vascular bed, which can lead to very sort of catastrophic infections that are very difficult to treat and have a high mortality rate. So bloodstream infections and bone infections, heart valve infections, etc. So as an infectious disease doctor, my work is intimately tied with substance use. These two things are just connected. And there are a range of services that we may be able to offer somebody who uses substances, whether they're HIV positive or not. Now, this is, of course, becoming especially popular. We've all heard about the opioid epidemic, or opioid crisis, as it's called by the media. And the common media narrative is that this is related to prescription opioids, that prescription opioids have increased the likelihood of using heroin. But the actual picture is a little bit more complicated than that. The price of heroin has gone down dramatically over the last 15 to 20 years. And so there have been increases in heroin use. There have been increases in prescription opioid use. There have been increases in sort of mixed use of both. But there have also been increases in overdose amongst those who are using opioids, and then increases in the use of other drugs such as stimulants. So the industrial production of methamphetamine has also led to an increase in stimulant use. And then for all drugs, there's actually been an increase in injection. So regardless of the substance that's being used, there's just an increased likelihood of injection in addition to that. So these are really multiple overlapping epidemics, as opposed to sort of one epidemic. Now, the good news is that HIV, despite this rise in injection, rise in substance use, we've actually seen amongst people who inject drugs a dramatic decline in HIV incidence over the last 30 years. This is just showing, this decline here is just showing amongst, from 2008 to 2014, but there's data going back that shows just a similar dramatic decline starting in the 80s and late 80s and early 90s, going down into the 2000s, that just the incidence of HIV transmission through syringe sharing, needle and syringe sharing, is actually quite low now. And why is that? It's because harm reduction works. So what is harm reduction? Harm reduction is a broad concept that means meeting people where they're at and trying to help them improve their health. But the most sort of commonly thought of program in harm reduction is syringe services, also sort of commonly called syringe exchange, although it's not a direct exchange. There are other harm reduction services like case management, social work, naloxone distribution to prevent overdose. There are actually a lot of education about safer techniques for injecting. And harm reduction has really been shown to dramatically decrease the risk of transmitting HIV. However, as I mentioned, hepatitis C is much more easily transmitted than HIV. And for reasons that are not fully understood, even as HIV transmission through drug injection has come down, there's been a dramatic rise in hepatitis C incidence over the same period. So harm reduction seems to work well enough to prevent the spread of HIV, but not the spread of hepatitis C. To the point that actually depending on the community, the seroprevalence of hepatitis C among people who inject drugs ranges between 40 to 70%. Very high prevalence. And when we look at the data for what's going on, there's a hypothesis that I have that has not necessarily been shown. But if you look at the age distribution, so this is the distribution of hepatitis C, new hepatitis C cases going back to 2006. And what you can see is this sort of classic picture of the baby boomers who were mostly infected with hepatitis C in the the sort of earlier drug epidemic, of injection heroin epidemic of the 70s and 80s, which is not talked about as much because of systemic racism. But this is where a lot of the sort of baby boomers were remotely infected at that time. And what's happened over the last 3 decades is this new generation of hepatitis C, a new generation of younger people who inject drugs who are now becoming infected with hepatitis C. They're sort of there's an endemicity that has arisen as injection drug use has spread through this new generation. So this raises concern that there is clearly enough unsterile syringe use going on that we could actually be set up for an outbreak of HIV amongst people who inject drugs, even in this setting. And that it could just be that we haven't hit that spread yet. And we saw this a little bit in Indiana when there was a rapid outbreak of HIV among people who inject drugs. Now, it's a little bit like night and day between the harm reduction, the availability of harm reduction in rural Indiana and New York City. So hopefully we're a little bit protected, but this is just somewhat concerning. So it's one of the reasons why thinking about hepatitis C is important for thinking about HIV in this population. Now, the other aspect of working with people who inject drugs is that they're highly, highly stigmatized. And that's across the board, but especially often in healthcare. And what we see is a lot of unmet needs. Even though there are a lot of services that I could offer to prevent and treat infections amongst people who inject drugs, they often avoid our clinic because they've had bad experiences with healthcare, whether it's in the emergency room being sneered at or told that they are just there to get high, etc. There are just a lot of unmet needs in this community. So as you can see, even though hepatitis A and hepatitis B are serious threats to people who inject drugs, only about 1/3 have been immunized against hepatitis A and hepatitis B. Only 7% of those who have hepatitis C have gotten treated, and hepatitis C is now very treatable. It's 1 to 3 pills for 8 to 12 weeks, and you just have to take it every day. With very few side effects. So that's been revolutionized in the last 6 or 7 years, but we have not gotten those revolutionary treatments to the population that needs them the most. And PrEP, less than 3% across a number of different studies of people who inject drugs, fewer than 3% of people who inject drugs are currently on PrEP, which, even though, as I mentioned, the HIV risk is fairly low in New York City, that's not true across the board, and you could see that I think for a lot of people it's still probably something they should be considering, and there's often concurrent sexual risk along with injection risk that they often go together. Only about 1/3 of people who inject drugs, despite all this need, have actually seen a provider in a clinic. Often they're being seen in emergency rooms or being hospitalized. Now, one of my hypotheses, and one of the hypotheses sort of driving this research, is that treatment for hepatitis C provides us the opportunity to reach out to this population. That if we can treat them for hepatitis C, we can then use that as a bridge to other services that may, for which they may have need, whether it be PrEP or HIV testing, STD testing, vaccination, or treatment for the underlying substance use disorder. Looks like this is, I think what we have to do as healthcare providers, but as a public health response, is think about if we're having trouble getting people to come to us, how can we come to them? How can we practice harm reduction of meeting people where they are at as a healthcare field? And I think what we need to do is bring infectious disease services to places that are frequented by people who inject drugs. Syringe service programs and other harm reduction programs are a great opportunity. Unfortunately, because of the prohibition of drugs, the incidence of criminal justice involvement in the population of people who inject drugs is astronomical. Over 90% of adults with advanced substance use disorders who inject drugs have had some experience of criminal justice involvement, depending on the setting. And I think when somebody does come through the emergency department, we need to make that an opportunity to link them to the care in the community that is going to be welcoming. So what I'm presenting on today is about one such effort that preceded my presence here at Columbia. Some faculty in the infectious disease division got a grant from New York State to provide hepatitis C care, hepatitis C management, and sort of diagnostic evaluation and treatment at a syringe exchange program, at a syringe service program. Our local program is the Washington Heights Corner Project, which provides comprehensive harm reduction, services. This work is a retrospective analysis of the medical records of all 102 patients that were enrolled between this program's inception in 2014 to the end of 2018. We did allow for a washout period before doing the chart review, so we excluded patients that had been that had done an intake to the program in the preceding 9 months prior to our review. We examined the charts to extract from provider documentation the substance use patterns and whether or not they have a substance use disorder, mental health comorbidities and whether or not they're being treated, housing status, criminal justice involvement history, opioid use disorder treatment, their history of treatment for opioid use disorder, and 96% of the patients were using opioids, at least to some extent. And then any mental health treatment. And we looked at the provider documentation over the course of the hepatitis C care cascade. So we looked at when they did their first intake or had their first visit with a provider, and then we looked at during the course of treatment and at the end of treatment, where did these things land? We divided housing. I don't need to get into this too much, but as you can see, housing was an ordinal variable. Part of the driver of this was actually we'd seen this study out of UCSF that showed this dose-response curve of housing for HIV viral suppression, where as you went from being street homeless to staying in a shelter or staying in an SRO to being stably housed, you had an increased likelihood of having viral suppression. So we classified housing as an ordinal variable. We also looked at opioid use disorder treatment. It was sort of more of a categorical variable, but you know, there is a little bit of ordinality in there in that we sort of, in some of our analyses, treated being engaged in treatment as different from being from actively using. But we looked at the range of different kinds of treatment. And then we constructed univariate and multivariate logistic regression models to identify predictors of successful completion of the care cascade, of all care cascade steps with documented sustained virologic response, which is just what we call Hep C cure. It's called sustained virologic response because in some tiny percent of the populations, if you were to do liver biopsies, you might find some evidence of inactive hepatitis C virus genes. But at the end of the day, SVR is pretty much cure. And then we looked at, as I mentioned, these changes in housing and changes in opioid use disorder treatment status, and also the changes in criminal justice involvement, or whether the criminal justice involvement occurred during the course of treatment. Although with these dynamic changes over time, ultimately we had these very small subgroups, so it didn't do any inferential statistics. So this is the overall care cascade. So out of 102 people who inject drugs, these were all people who inject drugs. Out of 102 people who inject drugs who completed an intake, who were found to have hepatitis C viremia, meaning they had hepatitis C, we were able to successfully treat 43, so about 42%. But what you can see is that most of the drop-off came between that initial provider visit and initiating treatment. And what we have to do is really only a few follow-up visits to do additional blood work to basically assess for the degree of hepatic fibrosis or the stage of disease, to assess for hepatitis B and hepatitis A and other comorbidities, get the genotype, and then basically go through the paperwork of getting the insurance company to approve treatment. So those are the main things that happen between this initial visit and this being initiated in treatment, but it requires follow-up serially, maybe 2 or 3 visits over a period of a month or two, depending on the person's insurance, etc. But once you can see also though, once we were able to initiate treatment, we had pretty good retention, and once of those who really completed treatment, we actually ended up having about 89.6 rate of SVR amongst those we know completed their treatment, which is about what it's just slightly lower than what was published in the randomized trials. So once people are able to take their medications, kind of like with HIV, once the access issues are taken away, often people, no matter where they are in life, no matter how unstable things are, they might, it makes it a lot more likely that they're able to treat it. Now I'm going to show you these are the care cascades broken down by the different risk factors we looked at. And the first couple, don't worry too much, but basically these are things that weren't significant. And what you'll see is that basically in each step, these bars are shrinking proportionally to each other. So this is the opioid use disorder treatment status at the outset at intake. And we did not find any impact of whether you were actively using or in a methadone program, doing stably in recovery, didn't seem to have an impact on your likelihood of making it all the way and curing your hep C. Interestingly, similarly, criminal justice. Now, part of this is that probably a lot of times people's criminal justice history was not being taken systematically or in detail. But we had a number of cases where we knew that people got arrested or were incarcerated either while we were already treating them or after they'd done an intake and before we had gotten their pre-treatment evaluation done. And that actually didn't have any impact on likelihood of success. Part of that is that there's actually a provider at Rikers Island who does hepatitis C treatment, and we were able to communicate with them and sort of make sure that the medications were continued in most cases. This is supposed to, one of these graphs is supposed to say housing, and this was an earlier version. I think I sent the wrong version. But basically housing looks the same. We did not have that dose response curve that we had expected that was actually sort of the inspiration for this project in a way. But what we do find is that mental health diagnosis and particularly mental health treatment was strongly associated with successful care. So again, just really a very good pairing with Nadia's presentation. And the way to see this is if you look, so the gray bars on top is that there is somebody who has mental health diagnosis documented and also has documented that they are currently have some form of treatment of that mental health diagnosis. The bottom blue bar is that they have no mental health diagnosis documented, and this orange bar that just shrinks dramatically is that there is a mental health diagnosis, but they have not gotten it treated. And what you can see is that the gray bar actually stays really doesn't shrink very much. The orange bar and the blue bar shrink dramatically over time, particularly the orange bar, not surprisingly. So having a mental health diagnosis without any treatment was the strongest predictor in the final model. Cocaine use was also a strong predictor. And there was a fair amount of cocaine use reported, often in addition to opioids, but for some people that was the primary drug of choice was cocaine injection. And people who were regularly using cocaine, that's the gray bar on top, were just less likely to make it all the way through and have their hepatitis C cured compared to people who occasionally use cocaine or are not currently actively using any cocaine. And this is these are our models. So you can see in the univariate analysis also age was a risk factor. So older age made it more likely that you were able to complete treatment. Interestingly, when we accounted for both age and cocaine use no longer became statistically significant. But I think mechanistically, I think that probably is still a real factor. It's just that we have don't have sufficient statistical power. But it came out in the multivariate model. And then the mental health diagnosis, having a mental health diagnosis and that is currently being treated, increased your odds of success by almost 3. So turning to what happened during the course of treatment, the sort of, it's a little bit like a trajectory, but just not as well done. So this is this is basically looking at opioid use disorder treatment during the course of hepatitis C treatment. And what you see is, so we had 30 patients who were actively using opiates. This is of the subset of people who completed treatment, because remember that for a lot of people who didn't complete treatment, we actually never saw them again, so we don't really know what happened to them. So of the people who completed treatment where we have consistent documentation about their trajectory or their course, there were 30 who were actively using opioids at intake. 14 engaged in some form of opioid use disorder treatment during the course of Hep C workup and treatment, whether that's getting into a methadone program was the most common thing, getting onto buprenorphine, getting into a sort of residential treatment program, or cold turkey in one case, interestingly. So without formal treatment, sort of self-treatment. That person actually stayed in recovery at the last visit. And what we saw is that so almost half of the patients who were actively using at the time of intake engaged in some form of treatment for opioid use disorder, and about 2/3 of those patients remained in opioid use disorder treatment by the last time we saw them, which for most patients actually is going to be at SVR, which is 12 weeks after completion of treatment. So we check the hepatitis C viral load 12 weeks after they finish their therapy course. And so for a lot of patients, it was actually at least sustained for a short period of time, a few months. And we don't know much afterwards. Similarly, with housing, of the 15 patients who were street homeless at intake, 5 of them actually had some transition in their housing towards something more stable. One patient who was actually, this is sort of this little asterisk, is because one of these patients jumped up here, and this patient, I believe, became street homeless again. So, but you have, and actually 3 of these patients were also engaged in opioid use disorder treatment. So you have this increase in functionality, increase in engagement in services for, I would say, a substantial proportion of the patients that we were successfully able to get on treatment and complete treatment. Now, of course, one of the major limitations is that we don't know what happened to the people who didn't get onto treatment. And we can't say that this is what the causality is, whether there's a reverse causality is perfectly, I think, a good explanation of this, that people are able to complete their hepatitis C treatment because they already were starting to move towards recovery. But I think for a certain proportion of the patients, there's probably both things going on, where you have people who are engaging in care, finding it useful. One of my hypotheses is that they're starting to experience some increased self-efficacy, and that this then leads to sort of further engagement. But we don't know. This is an observational, retrospective data of a small population that relied on chart review. So there's part of also one of the major limitations is that some things, though we ask everybody, we do a PHQ-2 screening for depression, the degree of depth of our mental health history was very variable from provider to provider. So, the fact that having no documented mental health diagnosis was also not, was associated with poorer outcomes suggests that they had mental health diagnosis. We just didn't document it or diagnose it. Because often patients are have just never seen a mental health provider for diagnosis. And then, of course, we do not know about what happened for those who were not in our, who didn't manage to make it at least a few more visits. We do have some data about people who didn't make it all the way or didn't get SVR, but we, don't have a lot of data. And then my conclusions slide didn't make it onto this one, but onto this version that I sent out. But I think that there are a few things that are worth pointing out. I think one is that, co-location of services really does facilitate engagement with this extremely hard to reach population. I think a lot of these patients are really probably not going to be able to make it into my clinic. In fact, we often for various reasons, try to get them to come to our clinic, which is literally, 12 blocks away, whether it's to start buprenorphine or for some like fancier fibrosis assessment, and we just can't make it happen. But bringing the services to where the people are, to where the people live their lives, can really make a big difference for this very vulnerable population. I think what would really benefit is probably co-location of not just infectious disease services, but also mental health services. If we could have had alongside us a psychiatrist or a psychologist who could help get that rolling, even though we did have a care coordinator who is incredibly good at getting people into various forms of treatment, to getting people, to helping people with all sorts of problems. I think having really, higher level of mental health care would really, which is also one of your conclusions, I think, could really benefit. I think for cocaine use disorder, we don't have as great of treatments for those, at least pharmacologically, as we do for opioid use disorder. But I think that we do know that that contingency management has significant benefit for people with stimulant use disorders, and I think that could very easily be incorporated into Hep C care. In fact, there was a pilot project at Montefiore of essentially, incentivizing the care cascade for hepatitis C that did show benefit. So providing financial incentives for negative cocaine, for those who are interested in getting into recovery from cocaine use disorder, providing financial benefits for both Hep C treatment follow-up and for cocaine abstinence might be of benefit. And I think that this also speaks to that we should really be thinking broadly about how we can bring these kinds of services together into the places where patients are, and that whether that's a syringe service program, jail or prison, even though that's probably the worst place, it is in the sense that it's a dehumanizing environment, a stigmatizing environment. It's also an opportunity, and we can try and reverse that stigma, reverse that dehumanization, and I think hospitalization is another sort of opportunity, and I have separate sort of lines of research on those other aspects. There's also an acknowledgements page that didn't make it. Which had several people in this room, Kate Elkington, my co-fellows, our team, the ID division, this T32. And thank you all for being here. All right.
Okay, thank you, Daniel. I look forward to the next things that you're going to do.
Okay.
It looks like there's a lot of work to be done.
There's a lot of work to be done.
Susan, I was going to ask you, because you must be very happy that we have two presentations from our fellows about substance use.
I'm so happy that I stood with another meeting, Nadia. I wanted to try this. Yeah, this is, both of them are wonderful work. I just wanted to say two things. One is that when this is published, in the discussion of harm reduction, I think there's another harm reduction message here, and that is that you don't have to have abstinence in order to, have successful medical outcomes. And also, I know we saw that people were in treatment, and often methadone treatment, which is a very densely covered treatment in the New York area. And I've done some work there, so I know that it's often true that people are still using either opiates, opiates, cocaine, other things, but still, I believe it's a stabilizing situation where you can get your opioid in the form of methadone, still hold on to your kids and pick them up at school and other stuff. So I think harm reduction is also about recognizing outcomes that are south of abstinence.
Absolutely, and I can speak to just an anecdote of a patient who, I've been following through this program, who had herself during Hep C treatment said she felt better, and that this got her excited about working on her health, got into a methadone program, and she said, towards the end, she said, look, I'm still injecting heroin, but I've reduced my use by 80%, and now I'm able to pick up my kids. Like, that was exactly what she said. And we're still working on getting her into mental health treatment, but this was, this, I think it speaks to that. The methadone, we know the data supports what you're saying as well, that it decreases criminality, criminal behavior, recidivism, decreases risk of HIV, decreases risk of overdose, decreases risk of essentially every negative outcome. And yet, I think for some reason we have this idea that it should be an instantaneous transformation when we don't expect that for any other disease. When we start a patient on insulin for diabetes, we don't expect them to instantly have perfect control over their glycemia. They need to learn how to use insulin. They need to learn how to modify their behavior, how to change their eating patterns, how to exercise. That never happens overnight. So I don't know why we expect the same with substance use disorders.
Well, I have another thing, but I don't want to be other people ask your questions. I
just want to, I have to go, but it was super. Oh, yeah.
Thank you.
Joe, you're Byron.
Yeah.
I don't mind getting one of the things about harm reduction I've found and have a couple of abstracts and trying to figure out the financial benefit is that syringe exchange has other benefits. And some of those is that in places where we have a critical mass of syringe exchange, we have less saccharitis, less abscesses, less endocarditis emission, less osteo. We have the same. And what I kept constant was pneumonia because you aspirate and you overdose. So that does. One of the fundamental premise early on was that meeting people where they're at. Were you, and so that is sort of an element of trust that does develop within the syringe exchange locale.
Mm-hmm.
Were you able to dissect how long someone had been going to the syringe exchange program and their acceptance of treatment?
Oh.
Because what we're finding is that element of trust in our hubs is the most important, so the trust of the provider and so forth. So I was wondering if you could look at it in terms of since you have a record.
That's a great idea. I think it's doable. It would be a little bit practically, there might be some challenges because our program is separate, technically not a part of the Corner Project. We have our own medical records, so we would have to sort of figure out how to get access to their client records, but I don't think it would be impossible. I think that's a great idea because I absolutely agree with you that that exposure, it sort of develops a community that has positive health norms. Just anecdotally from working in that community, that people start to help each other and see that as possible.
So to both of you, it's fantastic, and I'm biased too, so on multiple levels. But the issue around integrating mental health and substance use care into treatment, this is really a question for both of you, but start Candy. I think you're speaking to the converted here, and we all believe it's true, but it's a challenge. We have a supplement under ending the epidemic to do that in adults, but we also have a supplement to think about, improving support services for young adults. And I guess just your thoughts on how to, you gave one option, which is co-location, but I'm just curious about your thoughts about looking forward and how to do it and how to think about it to actually make it a reality. I know that's a really hard question, and many of us are struggling, but we both have a lot of ideas.
So I think of it sort of structurally. So I think there are certain things that have to change in terms of reimbursement that probably need to make it financially feasible for somebody to have a mental health clinic, fully functioning, just like we actually don't have a fully functioning clinic in this harm reduction program. We just have a sort of limited Hep C treatment program. Those same barriers, I'm sure, exist for mental health treatment. So, and they're a little bit beyond my pay grade, but basically, that I think there are barriers to providing those services as co-located in terms of getting state sort of, getting authorization to provide clinical services on site can involve some red tape that a small community-based organization is not necessarily going to have the resources to do. So I think partnering with larger academic medical centers that have an interest, but I think that's the other side, is that there has to be the interest within the mental health field, within particularly, sort of within the rising cadre of mental health professionals. I think that historically, because of prohibition, I was just reading the other day about the history that, in the late 19th century, you had this sort of early professionalization of addiction treatment that then actually was actually sort of devolved in the early part of the 20th century as this sort of social wave of prohibition as the answer rose, and you had prohibition of alcohol, you had the Harrison Act prohibiting narcotics and making it illegal to provide treatment. And I think that we're still feeling the aftershocks of that in mental health care. In the field of psychiatry for a long time, substance use disorders were seen as a personality disorder or characterological, and I think that the fields of mental health and the fields of medicine and the fields of public health need to really have a sea change in terms of how we view these things and get people excited about, doing this work with people who are still using substances and not demanding of them that they behave the way that we, want them to.
I think all I'll add is, just from my experience, in CASAH, I think two kind of major barriers are stigma, and so, services, they might not be perfect and they may not be co-located, but they do exist, and the challenge, I think, is helping people recognize that they can benefit from these services. And I think the other kind of piece is also making the services more appealing to them. So one of the things we've been working on with the supplement with Ryan White Part A is that we're trying to understand what young people want. So like maybe what's being offered is group therapy, and that is not something that they're interested in. So how can we make it something that's more appealing, less stigmatizing, and again, just kind of meeting them where they are.
I think actually, just thinking along those same lines, just a bit of a riff, but I think part of it is also co-locating will change the perspective in a way, because, for my patients, oftentimes the only time they've had regular care, whether it be primary medical care or psychiatric care, is in the criminal justice system. And so I think that there becomes this association in the population, and it's not always high quality. They're often they're right. They are rationally perceiving a low quality care system as being not necessarily very beneficial to them. And so I think being able to really bring a different kind of service to the community so that they can see an alternative way of viewing mental health treatment, I think also hopefully will kind of do that as well.
Ooh, 3 more questions.
Nadia's had a question for a while, so
Okay, you go first.
I was really struck by the giant drop in the cascade from like where they had to do all the administrative things, like getting insurance, and so the parallel that I was thinking about is with HIV, there's this movement towards same-day ART initiation, right? So it's an emergency. We're gonna all hands on deck. We're gonna figure out insurance. We have these vouchers that we can use to get treatment to make that not a barrier. And given that hepatitis C is even more infectious than HIV, I'm curious if you think such a model could work in this environment, and what would that take?
So there's a randomized trial of that very thing going on at the Lower East Side Harm Reduction with Ben Eckert at NYU, where they are basically if you test positive for the antibody, I think they draw blood for the viral load as well, but they basically, with the rapid test positive, they give you a week or two of treatment, and they say, come back on this date and we'll have your results. And then they, basically continue it if they have Hep C, or they just say, okay, bring back your pills and we'll pay you for them if they don't have Hep C. And they call them with the results and tell them what to do. And I think it'll work.
Everybody gets it. I started with Heiner, and then Susie, and then Susan.
To mental health services, don't they also need employment skill training, if you like? What is the job situation of these people? And is anybody doing something about their job skills and employment opportunities?
I think so. Often, and this is I don't know formally what is available in that regard, but I think often that is the sort of third or fourth step on the Maslow's hierarchy, and they have to first work on 1 and 2. So often those services are not available. But also, one of the things that harm reduction does is actually provide employment for a proportion of the population. So often people who work in syringe exchange are themselves people of the community who are using or in recovery. So provides that. But I think it's a good point that certainly once we have the services in place to help stabilize people, that's one of those services that will be part of the critical package.
So you mentioned PrEP somewhere in one of these slides, but then I didn't see any more about it. Is that one of the things that's also not very high on the, or low on the hierarchy of interest, or?
That has been our sort of clinical impression for most of our patients, is that if they are not describing high risky sex, because we know that the incidence of HIV through direct transmission is so low for people who are actively engaged in syringe exchange, and because often, there are just so many other things that we would probably prioritize above that, like getting them into mental health treatment. People do get referred to our PrEP clinic. There's also the problem that there is a burgeoning black market for antiretroviral drugs that is in New York City, that is fueled by unscrupulous pharmacies buying back antiretroviral drugs from people. So often what we find is that people who do get referred to our PrEP clinic are not taking it, and they're selling it. So
Totally sold on co-location and integration, but in terms of scale up, I think one thing that a lot of programs do have are navigators.
Mm-hmm.
And I think that it might be useful in a place other than New York, where there is transmission, to go head to head with whether really available, really dedicated, good navigators, which I believe that you have.
Yes. We have an unbelievably good
really
navigator.
Staying on that 12-block trip or whatever the trip is,
Mm-hmm.
to get to the needed next step service. How does that fare against co-location? This is a very hard and large study to do, and I think it can only be done in places where the care isn't as good as it is in New York. But for instance, Lisa Mesh and colleagues in Miami, in their syringe services, I think, are individually randomizing. Not that I love that, but I think they're individually randomizing people for Hep C and also for PrEP to getting it on location or having some kind of good active referral navigation.
So we do have an excellent peer navigator. I mean, he's unbelievable. He knows what street corner people buy their drugs at. He knows what, where they sleep, who they sleep with. He knows everything, and it's pretty amazing, and is able to get people. And oftentimes when we did identify a mental health diagnosis, we would say, well, this person's depressed. We really should try and get them into treatment. I think that peer navigation is a very important first step, and I think you should. I agree with you that in places where you don't have a peer navigator, prioritizing a mental health provider without a peer navigator, without case managers, makes no sense. I think we should have an army of peer navigators and case managers. But I think that there is a subset of the population that's just not enough for. So, for example, in the transitions clinic in the Bronx, which I have a little bit of a relationship to, which provides peer navigation following release from incarceration, and they have a peer navigator who has lived experience of criminal justice. In their HIV, still only about 50% of people are retained in care. And like the best peer navigation intervention randomized clinical trial, the LINK-LA study, still 50% was actually a very good outcome for peer navigation compared to the 36% baseline. But there's still just a population that needs more, and I don't know what that is. I think part of it is mental health care. I think also part of it is social network or peer, sort of more peer activation, more peer involvement, true peer as opposed to peer like a professional peer navigator. So somebody who is already part of your circle helping you, I think is gonna be a bigger benefit. But that's just me speculating, and telling you a little bit about what MIK is.
Lots of ideas, a lot more work to be done. Nadia and Daniel, thank you so much.